before we get into the episode, I've got to tell you about something that I use all the time, and that's my X shears. These aren't your run-of-the-mill trauma shears that bend after one tough shift. X shears were designed by someone who gets it. A nurse and paramedic who is just tired of disposable junk and clunky tools that never held up. Y'all, these things are beast. Heavy duty, stainless steel blades, the titanium coating, super comfortable non-slip handles, and yeah, they come in a bunch of colors, including my favorite, purple. They're easy to clean, built to last, and come with a 5-year warranty, which is basically unheard of. And this is new, the X Shear Mini. It's only 6 inches, and it fits in your pocket or a small kit. It still cuts like a champ, but it's perfect for those lighter situations where you don't need the full-size version. So, wherever you care for patients, you want a pair of shears that actually work, and X Shears is it. I promise they'll be your new favorite shears. And you can use the code RAPID10 to get 10% off your purchase. So check them out. I put a link in the show notes for you. He is getting worse. 6 hours later, he's been on the PCU floor, progressive care floor. He's having increasing tachycardia, now in the 130s. His blood pressure is trending down, 88/53 now. He's needing more and more oxygen. He's progressed into the heated high flow nasal cannula, so higher flow, higher oxygen FiO2. He has new cool extremities and delayed capillary refill, which always makes my sphincter tighten up. Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life. Today's episode is an important one for nurses across emergency, critical care, and rapid response, and really any acute care setting. I'm joined by Dr. Mark Creager, lead author of the new American Heart Association Multi-Society Guideline on the evaluation and management of acute pulmonary embolisms. This guideline represents a major shift in how we classify PE severity, how we recognize early deterioration, and how we treat patients in ways that minimize hemodynamic collapse. So we're talking about this guideline, how it moves away from older PE labels, how nurses can recognize progression from moderate to high risk using the new classification system, and what's changed in frontline management, including the preference for high flow nasal cannula over early intubation, low molecular weight heparin over unfractionated heparin. We talk vasopressors and the nurse's role, how to take the best care of these high-risk patients. We also explore the role of pulmonary embolism response teams, or PERT, and why early multidisciplinary involvement matters. This episode is about translating evidence into bedside action, especially for nurses who are often the first ones to recognize that a PE patient is worsening. All right, let's meet Dr. Creager and dive into this case together. Welcome to the Rapid Response Nurse podcast. I am so glad to have you. For those who don't know, Dr. Mark Creager, he is the lead author of the new American Heart Association Multi-Society Guidelines for the evaluation and management of acute pulmonary embolisms. This is something as a rapid response nurse that I am very excited about. I love the new guideline. I love the new verbiage. So I'm stoked to have you on the podcast today. Welcome.
Well, thank you very much, Sarah. It's a pleasure to be here.
So I'm just curious, how did you get involved with this AHA guideline writing, the team? Like, how were you asked to do this? Were you like, I would love the opportunity. How did this happen?
Well, that's a good question, Sarah. And there's a long answer, but I'll try to give you
Okay.
the short version. So I have been a long-time volunteer for both the American Heart Association and the American College of Cardiology. In fact, I'm a past president of the American Heart Association.
Awesome.
These two organizations have for many years put together clinical practice guidelines. And these clinical practice guidelines really cover a wide swath of important cardiovascular diseases. They've never had one in acute pulmonary embolism. Other organizations have, but the joint AHA ACC Clinical Practice Guideline Committee decided it was timely to do that now. Timely because there's been so many advances made in the diagnosis and treatment of patients with acute pulmonary embolism. So first, there was a decision to have these guidelines. Second, as I mentioned, I'm a longtime volunteer of both organizations, and I am a cardiologist, but my area of expertise is vascular medicine. And within vascular medicine, a major area, of course, is pulmonary embolism. So I was deemed to have the expertise to really cover this topic. And of course, I've had leadership responsibilities. The Joint Committee put together, along with me, an outstanding writing committee. And I encourage all your listeners certainly to look at the guidelines, read the guidelines, but even just looking at the title page, you can see the many organizations that are represented and contributed to these guidelines. So it's not just the American Heart Association, the American College of Cardiology, but others as well. And the writing committee, which exceeded 30 people, really was a multidisciplinary writing committee that represented many different aspects of the folks, the team that's involved in the care of these patients.
Gotcha. That is exciting. Okay, so I think the best way, at least for the way that I learn, is to introduce these new guidelines, the new clinical categories with a case. And as the case evolves, we can talk about how we can apply these new guidelines to the case. Does that work for you?
Works for me.
Okay, let's do it. So here is Mr. J. He is a 58-year-old male with obesity, recent right knee arthroplasty. He presents to the ER with acute dyspnea, pleuritic chest pain, and anxiety, because I too would be anxious if I couldn't breathe. His vital signs weren't the worst I've seen. Heart rate is 118, blood pressure 118/76. He's breathing 26 times a minute. Initial oxygen saturation was 89% on room air, but improved pretty well with 4 liters of nasal cannula. Now he's at 94%. ER did some diagnostics. CT angiogram showed bilateral segmental pulmonary emboli. Troponin was a little bit elevated. BNP was elevated. Did a bedside echo. And yes, he had some RV dilation. Okay. So for initial management, they did some anticoagulation with low molecular weight heparin. His oxygen therapy kind of escalated a little bit more to a high flow nasal cannula because he's still having increased vertical breathing. He was sent to the step-down unit for close monitoring. Okay. We've all seen this patient. So let's pause for a second and talk about the new classification system and take a moment to classify this patient. So Dr. Creager, can you walk us through the new A to D classification system? Why did you guys go with this one instead of the previous, like massive, submassive, low, intermediate, high risk? Tell me all about this one. I'm excited for it.
So thank you for starting with this, Sarah. This is probably one of the most impactful parts of these guidelines is this new AHA ACC Acute PE clinical categories. Mm-hmm. And I am going to delve into that now with you as we just discussed. But I'll start by saying, and really reaffirming what you said, this is not an uncommon presentation of the folks we see with acute pulmonary embolism. One of the most frequent is a patient just like this. And as you'll understand in just a minute, he fits into category C3 with a positive respiratory modifier. Let me go through the clinical categories, but first give you a little background. So you just alluded to 2 prior classification systems. One was really promulgated by the American Heart Association well over a decade ago, where there were 3 categories: low risk, submassive, and massive. And although that was somewhat informative, it really didn't drill down well in enabling us to really understand who these patients were, the more subtleties of prognosis, and what treatment should be used depending on the categorization. Probably in late 2000, about 2019, the European Society of Cardiology Pulmonary Embolism Guidelines came out with another classification system, which you also alluded to, that had 3 major categories, and one of those was subdivided. So it was the low risk category, the intermediate risk category, which was subdivided into low intermediate risk and high intermediate risk, and then the high risk category. And that really built upon the prior categorization, but really wasn't really nuanced enough or descriptive enough to really help many folks best understand what's going to happen with these patients, what their outcome is likely to be, and importantly, what would be the most evidence-based treatments for them. So in this new AHA ACC PE clinical categories, we have 5 major categories, and we lettered them A, B, C, D, and E. As the letters go up, the severity gets worse. And in many of these categories, there are subcategories. So A is the least ill patient. These are patients which we're deeming to have subclinical pulmonary embolism. What does that mean? That means that they're not having any symptoms. And the reason a pulmonary embolism may have been detected is because they were having a CT scan for another reason. Let's assume maybe surveillance for lung cancer, and a subsegmental pulmonary embolism was identified. So these folks are really pretty low risk. They're not having any symptoms, and their management outside their comorbid condition, but their management of pulmonary embolism can be really outpatient. They don't have to stay in an emergency department. They don't have to stay in the hospital if that's the reason that's being considered, and they're sent home. And we'll talk about management later for the different categorization. The next level is category B. These are symptomatic patients, but they're not that symptomatic. They're mildly symptomatic based on history, physical examination. We have a number of clinical risk assessment scores. And if they're very low in their clinical severity score, and they have subsegmental pulmonary emboli, or even non-subsegmental pulmonary emboli, they're category B, and B1 is subsegmental and B2 is non-subsegmental. The C patients, they're kind of the common patients that we all encounter, the ones that end up really requiring more thought and more decision analysis on how to best treat them. So C are patients who are symptomatic, very similar to the patient you described. And when you do a risk assessment score, clinical severity score, theirs is elevated. And we divided C into 3 subcategories, C1, C2, and C3. And this will be reminiscent of the intermediate risk category from the European Society of Cardiology. So C1, they're symptomatic. They have an elevated clinical severity score, but they don't have elevated biomarkers, and they have normal right ventricular size and function. C2, they have either an elevated biomarker such as NT-proBNP or troponin, or they have abnormal right ventricular function. And C3 is all the above. So they have both elevated biomarkers as well as abnormal right ventricular function. And within this category, we added a respiratory modifier because it's not only these measures that we consider when we're seeing how well a patient is doing, but what's going on in their respiratory status. So if they're hypoxic or tachypneic or requiring, as the patient you described does, that's a positive respiratory modifier. As we move on to the next category, that's category D, we call that incipient cardiopulmonary failure. And these patients they're sick. And these are the ones that you're going to certainly encounter in the critical care unit. These folks may have transient episodes of hypotension, that's D1, or D2, which is a condition we're identifying as normotensive shock. We can discuss that a little bit later as well. But clearly, they're really showing evidence of hemodynamic compromise. And this too has a respiratory modifier, meaning they're hypoxic, and they require supplemental oxygen like high-flow nasal cannula. Category E is the sickest patients. They have cardiopulmonary failure. These are folks who are in cardiogenic shock. They have persistent hypertension, that's E1, or the most severe is E2. These are people with recurrent cardiac arrest. Bring them back and they arrest again. And that too has a respiratory modifier. So those are our 5 major clinical categories and the subcategories that constitute the new scheme.
Gotcha. So just at first glance, it looks more complicated. However, I like it more because I feel like it's more granular than before. And we can easily see where patients fall, not just in this one moment in time, but as they kind of progress along the continuum. Maybe they're worsening because they went from a C, they're looking more like a D now. We need to get some stuff going. Or 2 days ago, they were a D, but now look, they're doing so much better. Their vital signs are improving. Their oxygen support is less. We can see patients moving along that. So I love this new guideline. I think this image is so good. I'm very excited to apply these clinical categories for practice. I think this gives us a shared language to know how sick is this patient that we're referencing.
You're right, Sarah. And the image you're referring to is in the guidelines. I don't know if you're showing this on your podcast.
Yes, I will say that. There's a link in the show notes to actually visualize this.
When we first discussed these categories, the initial concern was, whoa, we are making this too complicated. People won't use it. But it's exactly as you said. And taking me for an example, I'm using it all the time now. And what you heard me say, it's on the top of my head. I know this cold. And I think it's really easily adaptable to anyone who's taking care of patients with pulmonary emboli.
Yeah. And I think the ABCDE imagery is pretty common. We use it in trauma. We use it for cardiogenic shock. Like, we use this all the time. This is not that weird to have an ABCDE escalation of badness. So I think it's good. Whoever came up with this, I applaud them. I think it's awesome. Okay, so now let's apply it to this case. So this same patient, he is getting worse. What do you know? So 6 hours later, he's been on the PCU floor, progressive care floor. He's having increasing tachycardia, now in the 130s. His blood pressure is trending down, 88/53 now. He's needing more and more oxygen. He's progressed to the heated high flow nasal cannula, so higher flow, higher oxygen FiO2. He has new cool extremities and delayed capillary refill, which always makes my sphincter tighten up whenever I see that on patients on the med-surg floor, and decreased urine output. Okay, so the primary nurse recognized this patient's declining, activated the rapid response team. So we show up, we transfer the patient to the ICU. We had to initiate norepinephrine to get the blood pressure stabilized. We added vasopressin to reduce pulmonary vascular resistance, not have to use quite so much catecholamines, and activated the PERT team, PE response team, to guide advanced therapies for this patient. Okay, I've seen this patient so many times in my career. So let's talk about it. What category would you say this patient's falling into now?
So the way you described it with the hemodynamics, he's borderline between really a D category and an E category.
Mm-hmm.
He's clearly showing evidence of shock. He's got decreased urine output. His extremities are cool. And his blood pressure, the systolic blood pressure, is now under 90, just under 90, but it is.
Mm-hmm.
So by strict definitions, he's really moved from a C3 to an E1 with really persistent hypertension, and is going to require additional treatment. But really, he's on the borderline between, I would say, a D2 and an E1. But certainly, he's moved beyond the C3, which he initially was categorized as.
So additionally, he was admitted to the floor just to get some heparin or some sort of anticoagulant. But now, what are we going to be doing for this patient? Or what are our options, I guess better said?
Well, first of all, you got to move him to a place where he can be really actively monitored in treatment, which is the ICU. So hospitalizing him at the first time, as soon as he showed up in the emergency department as a C3R, it was clear he had to be in the hospital to watch in case he deteriorated, which he did. Now he really needs to be in a place where he can be actively monitored and more effectively treated, which is the ICU. So now he's in the ICU. You got to start dealing with the appearance of shock, which is to begin treatment, which would be a vasopressor to start, vasopressor, inotrope, and then depending on how well he does, adding on from there.
So I want to pause and talk about oxygen therapy for this patient. I feel like 20 years ago when I started my career, if we had seen this patient working to breathe, requiring more and more oxygen, blood pressure's not so, we would want to intubate this person, take the airway, take over. But I feel like there's been a shift away from quickly intubating and trying to optimize these people with heated high flow or some other oxygen therapy without intubating. Can you talk for just a little bit about maybe why intubation should not be our first go-to if we can avoid it, doing other things to optimize?
Right. So I had the same experience as you. Again, as your listeners know, there's a number of ways we support oxygenation and ventilation in folks who are having respiratory compromise. That includes a conventional nasal cannula, high-flow nasal cannula, non-invasive mechanical ventilation, invasive mechanical ventilation. And they each have unique effects on gas exchange and hemodynamics. But we now know from a number of randomized controlled trials and reviews of those trials that the use of high-flow nasal cannula or non-invasive ventilation, it's well tolerated. It improves oxygenation, improves the work of breathing. If you were to go a little bit further than that, as we do in other circumstances with intubation and mechanical ventilation, ironically, that can cause adverse consequences because the positive pressure associated with that both decreases right ventricular preload, it increases right ventricular afterload, and can further compromise the patient and, in fact, lead to a risk of cardiac arrest because of decompensated right ventricular failure.
Yeah, so for patients that are already struggling with the RV because there's a clot in the way of forward flow, now we can make it even harder with positive pressure ventilation, reducing preload, increasing afterload. So yeah, maybe we should not do that to the right heart if it's already having a hard time. Hey guys, I'll get back to the show in just 1 second, but before I do, I have a request. If you have ever gotten any value from this podcast and you want the show to continue to grow, to access more awesome experts in the field, and to keep providing you with more nursing knowledge and inspiration, could you take a minute to leave a rating and a review? Those reviews on Apple and Spotify go a long way in getting this podcast in the hands of more nurses and bringing new guests to the show. And they just make my day to know that my stories and nerdy patho breakdown are helping other nurses thrive, or at least survive. So if you're feeling up to it, I'd love to see a rating and review from you. Thank you so much. Now back to the show. Okay, I also wanted to talk about vasopressor therapy. I mean, vasopressors have complications and side effects as well, but if your patient's blood pressure is tanking and you have to still perfuse all the vital organs, which vasopressor are you reaching for? Which one are you trying to avoid? Can we talk about that for a moment as well?
We can, and we talk about that certainly in the guidelines. So we have evidence, some indirect, from animal models, but also from humans with shot, that norepinephrine is an excellent vasopressor. It increases systemic vascular resistance. It does have modest inotropic effects, but it doses less than 15 mics per minute. Norepinephrine really has little or no effect on pulmonary vascular resistance. And that's important because you don't want to be increasing pulmonary vascular resistance, and the consequence would be worsening right ventricular function. So there's a net favorable effect on the systemic vascular resistance, pulmonary vascular resistance ratio. That changes, however, when the doses start to exceed 15 mics per minute. Then norepinephrine will increase pulmonary vascular resistance. So at that point, if the patient still requires additional support, it's time to consider another vasopressor agent.
Gotcha. Okay. Can we talk about vasopressin a little bit and its value in the PE patient population, right, the crashing PE patient population?
So that would be my next go-to agent. So have the patient on norepinephrine, we're dialing it up, but clearly the patient needs more. So vasopressin obviously acts differently than acting on catecholinergic receptors. It acts on vasopressin receptors, and they're really more prominent in the systemic circulation. So vasopressin increases systemic vascular resistance, but while sparing the pulmonary vasculature. So it actually leads to about a 45% decrease in the pulmonary vascular resistance, systemic vascular resistance ratio, particularly if you compare it to something else like phenylephrine.
Gotcha. Which sounds very beneficial for this particular patient population.
Yes, it is. It is.
Okay. And then the other, speaking of medications, can we talk about low molecular weight heparin versus unfractionated heparin?
So now we're really talking about the broader population of patients,
yes,
with acute pulmonary embolism. So if we can refer back to our AHA ACC Acute PE clinical categories, those in A and B, so they're the ones that are incidental or mildly symptomatic with low clinical risk scores, they typically can go home, from the emergency department on a DOAC, a direct orally active anticoagulant. But for those in categories C through E1, who are coming into the hospital, and like the patient you described who came in and then started to deteriorate, you might want a little bit more caution in anticoagulating them and not put them on a DOAC right away because you're not actually sure what the next step will be. So a parenteral agent is the way to go. So what are we talking about with parenteral agents? We're talking about either unfractionated heparin or low molecular weight heparin. We have a class 1 recommendation for low molecular weight heparin over unfractionated heparin based on data from the clinical literature and meta-analysis of that data that indicates that the use of low molecular weight heparin reduces the risk of recurrent venous thromboembolism more effectively than unfractionated heparin without increasing major bleeding. But particularly when we're in the hospital, we're in the critical care unit, I think all of us know low molecular weight heparins have really predictable pharmacokinetics. Doesn't require routine monitoring, and the dose adjustments that go with unfractionated heparin, and it's also associated with a lower incidence of heparin-induced thrombocytopenia. So it's easier to use. You're not constantly, monitoring the efficacy of unfractionated heparin. You're not worried that you're underdosing or overdosing. You really have steady state dosing. So it's effective and it's easier to use.
So question, because I'm not the one that prescribes these medications, but just in my anecdotal experience, I feel like I'm not seeing this in practice. I feel like we still use heparin infusions all the time, and we're not so much using the other options. Is this the first time we're seeing this in guidelines or recommendations, and that's why it just hasn't dispersed widely yet?
So change is hard. We've all been, right? Everyone's been using unfractionated heparin. Why? Because, I can turn it off. If something bad happens, I can turn it off and the effect will go away. And sure, it's shorter acting than low molecular weight heparin. But what we're trying to do is effectively anticoagulate these patients with acute pulmonary embolism and do it rapidly. You can't do it as rapidly with unfractionated heparin in many circumstances.
Mm-hmm.
And, failure to really hit the mark really increases the risk of thrombus propagation and recurrent pulmonary embolism if you're too low. And if you're overshooting the mark, you're increasing the risk of bleeding. We really got to get away from this thinking that we need to be facile in turning off the heparin because something bad may happen. It's really so much harder to use unfractionated heparin than low molecular weight heparin. And we want these patients anticoagulated.
Especially from a nursing standpoint, right?
Exactly.
We're poking the patient constantly to get their lab values. We're titrating the drip. And
exactly.
Nothing more complicated.
We've got to get away from this old thinking. What we've always done is not always what we should be doing.
Amen to that. Let's smash the old dogma and do what the literature is telling us is best for our patients. Amen to that. Okay. I also want to talk about PE response teams, because I feel like this is very heavily discussed in the guidelines, and I'm a huge advocate for. I'm curious, are there recommendations for when to activate the PE response team? Like at what level for the clinical categories, or is it certain? I'm just curious if there's recommendations for that. I know what my hospital has. I don't know if that's across the board though.
We recommend activating a pulmonary embolism response team for categories C, particularly C3, but C up through E.
Okay. All right.
You don't need it for A and B because, right, these people are really not that symptomatic. They're going home from the emergency department.
Okay. And then who are you recommending should be on a PE response team? What interdisciplinary makeup would be ideal?
So that's a great question. It really, again, depends on the institution where the expertise lies. So we have a figure in the guidelines, and I would, again, refer your listeners to that figure. So it includes a broad number of disciplines that would constitute the team, again, depending on local expertise. So whether it is pulmonary and critical care physicians, general cardiologists, interventional cardiologists. I mentioned earlier, I'm a vascular medicine expert. Places have that. Emergency medicine, of course, because that's really the first people who are seeing these patients. Some institutions, vascular surgery or cardiac surgery, depending on who's really responsible for some of the advanced interventions, interventional radiology. And really, I can't emphasize this enough, nursing. Nursing should be involved as well. Pharmacy also. Mm-hmm. And I'm sure I'm leaving out the important groups. So it really depends on the institution, what resources are available, but it's really getting heads together. Now, I'm not suggesting, none of us are suggesting that when a patient shows up in these C3, that you suddenly have trying to convene a meeting of 10 people urgently to discuss, the patient. But there should be members of the team readily available to meet the patient early on, either in the emergency department or shortly after they're hospitalized, who form the crux of the team, then can bring in other members of the team to work on decision analysis and management.
Love that. We can definitely see a benefit in having a PE response team ready to be activated, getting everyone, all the disciplines, all the departments together at one time to make a quick decision for this patient, and then to expedite getting them towards whatever intervention we're choosing as a team. So I'm curious, we know this is ideal. Not every hospital has those resources to have a dedicated PE response team. So what would you recommend for those maybe smaller hospitals? How can they advocate for this early multidisciplinary involvement if they don't have this PE team established?
Right. So depending on the size of the hospital, and the expertise that's available, they should partner with a larger hospital, tertiary hospital that has the expertise and be able to make calls to their pulmonary embolism experts. And they can have video calls. I mean, today it's so commonplace. So I would say don't rely just on, if you don't have the expertise or you don't have enough knowledge in managing these patients, reach out. Help is readily available. So that's one really good example of what smaller hospitals should be set up to do. So they don't have to set up their own pulmonary embolism response team, but they should have ready access to the expertise that partner or other hospitals that can help them. And keep in mind, if it's a smaller hospital, they may not have other things such as advanced therapies that a patient may, should be considered on many patients that are severely ill. So they, in some situations, they're going to be transferring a patient from one place to another.
Yeah. And I can't stress that enough. I work at a tertiary care center, so we receive those patients that come to us for thrombectomy. And I feel like far too often, the activation of our team or the request for the transfer happens a little bit too late, and the patient declines en route, and then our options are limited. It's so much easier to do the thrombectomy on someone who's hemodynamically stable, but if they continue to decline en route, it's too unsafe to do the thrombectomy, and now we're just having to go with like a thrombolytic. I mean, that's fine. Do what you got to do. But at what point would you say it's time to make that transfer? It's time to push for moving the patient to a tertiary care center versus just managing it in the hospital that they showed up to?
So that's a good question. We actually have a section in the guideline as well in terms of inter-hospital transfers. So it's really, you got to find the critical moment when you have the right patient. Obviously, one that's not ill doesn't need to be transferred. A's or B's are going home to the emergency room. Most C1s and C2s can be managed locally. As you're getting up to C3, it's getting a little more concerning. So I would start thinking about it then. And then you're moving on to the more seriously ill patients. What you don't want to do is try and transfer a patient who's incredibly unstable, because that transfer will not go well. So obviously, if they're an E2 patient, that's, they really might be too sick to transfer. And E1s, it depends if you can at least stabilize them enough to have them transferred. So it's the very sick patients, so C3, Ds, some E's, if they can be stabilized, and they should be moved.
Gotcha. All right. Well, this is very helpful. Before we close, could you summarize from what you perceive nurses need to know? What are like the key takeaways from these new guidelines? What would be the top 3 things you want my listeners to take away from our conversation today?
All right. Well, let me emphasize that nurses are a critical part of this. Maybe I'll say that because my wife's a nurse, but I would have said that anyway. I work with nurses closely. I have my entire career. They're really an amazing part of the team, in particular, critically ill patient. So there's a lot of important messages. It's a long guideline. There's probably over 75 pages. And it's worth at least a read. And if not having, you're not going to remember everything you read in a long guideline, but there's pocket guidelines available. Just have it available. I mean, the healthcare providers taking care of the patient should be familiar with that they have a resource they can go to. So important, as we discussed early on in this podcast, is the new clinical categorization. Become familiar with it. It's really going to be helpful in understanding how to really think about these patients and what might be the most effective and safest way to manage the patient. So I would put that as number 1. But we have a number of other guidelines, and it really depends where you are in encountering these patients. We have recommendations, a guideline that are certainly relevant to the first encounter with a patient in the emergency department, what you should be thinking about, who should go on to diagnostic testing when patients present, like yours did, with shortness of breath and chest pain. So who should go on and get for a CT? Once the diagnosis is made, which category do they fit in? What's the appropriate first management on these patients? And then we talk quite a bit about direct early acting anticoagulants, who should get that. We go on to talk about later the follow-up of these patients, who requires extended use anticoagulants, who needs to be watched for long-term complications like chronic embolic pulmonary disease. So there's a number of things in there, and it's hard for me to pick one other than the one I just mentioned, the clinical categorization, that needs to rise to the top of most important, because it's all important.
I agree. I feel like this just gives us shared language. If the nurse can call the doctor and say, hey, I feel like our patient's transitioning from a C3 to a D1 with some episodes of D2, their blood pressure keeps kind of tanking a little bit. I feel like that just helps us be on the same page to care for this patient collaboratively so much better, which is why I love these new clinical categories. Creager, thank you so much for translating complex physiology into actionable guidance. Like, these guidelines reinforce something that nurses already know, that early recognition, thoughtful escalation, and avoiding iatrogenic harm is just as important as the advanced therapies that we are trying to shoot for these patients. So for my listeners, remember that pulmonary embolism, it's not a static diagnosis. Like, patients can evolve. The classification system gives us a shared language, and your bedside assessment often is what determines when lives are saved. So thanks always for listening. Stay curious, stay vigilant, and keep using your voice to advocate for your patients. Dr. Creager, thank you again for your time today.
Well, thank you, Sarah. It was a real pleasure.
Thanks so much. Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.